All right, I'd like to thank the panel as well for a great start to today's discussion. Also thank Larry and Peter, or add my welcome to Larry and Peter for all of you who are with us today. I know this is a propitious day in health policy with, I think, the Burwell-King oral argument starting right about now, but that just goes to show how important a range of issues are in healthcare, including the ones that we're talking about today in terms of next steps on health information technology policy. I'd like to ask Farzad and David to come on up and get mic'd up while I introduce them. Let's see, I know they're here. Maybe they're off listening to the oral arguments for a minute, but they are here. So. Let's see. Okay, here we go. David, great to see you. Right on cue, and Farzad right on cue. So come on up, sit in the middle there while I just do a minute of introductions. David and Farzad really don't need introduction to people who have been steeped in health IT issues and been following some of the debates and discussions about next steps for health information technology policy. But for the purpose of this panel, which is perspectives on where we've been and where we're going in the government's role in transforming care through using health IT, I couldn't think of a better couple of perspectives. So we're going to focus on some of what's happened in the past, as well as the current programs and where they're headed, the trajectory towards more optimal use of health information technology. Thanks to the first panel, we've got a great foundation for this discussion. I'll be moderating it. I'm just going to briefly introduce David and Farzad, and they both, their career trajectories illustrate, I think, one of the main themes that came out in the first panel about the importance of thinking of health information technology as a very critical means to the end of better health care, with the emphasis in the last panel on such issues as improving quality and lowering costs through interoperability and the other analytic and support tools that health IT can provide. David went from a prior career and very much engaged in developing and using IT systems at the regional and hopefully more national level to his work at the Office of the National Coordinator, and now has moved on to being a managing partner and CEO of Health Evolution Partners, which is using innovative electronic data systems, among other things, to bring consumers and disruptive innovations more into healthcare. Farzad, after his work in public health and health policy and in the Office of the National Coordinator, spent some time with us here at Brookings as a visiting fellow working on issues related to smaller physician practices, being able to take steps to lead on healthcare reform and move towards more population approaches to health management, and I think was so engaged and impressed with what he found there, he went on to found a company which now is the CEO of Aledade, which is focusing on supporting smaller physician practices and making this change towards healthcare transformation around improving health and lowering costs. And in all of these areas, health IT continues to be a major set of issues. So can't think of any better people to provide a perspective on where we've been and where we're going in terms of health IT policies and their impact. And I'd like to start maybe with each of you. David, first, since you were there earlier, you were there at the beginning, really, for the Office of the National Coordinator. I know people have talked a lot today about the High-Tech Act and the meaningful use incentives, but there was congressional involvement and presidential bipartisan leadership to try to make a push on health IT, now going back a decade, on interoperability and on trying to fulfill this vision of the potential for health IT to make a difference. So if you don't mind just starting us out with just a few minutes on where we came from and where we are now from your standpoint.
Sure, Mark, thanks. And I would comment that I clearly have failed the colorful sock test up here, so those of you in the front can see. Yeah, you know, it's funny, we're a decade in, and the thing that has been immutable are the goals. You know, having clinicians have information, having it be shared, making it accessible to consumers, using it to drive changes in the healthcare industry, those have been immutable, and I think those have been the roots that have held together so many of the initiatives and so many people that have gone through this effort. What's changed to the strategies, and I think we're moving into the third generation of strategies. We had the early phase where it was very much about getting people lined up and setting expectations correctly and trying to leverage the tremendous human capital that existed in the industry and the enormous groundswell from people, from clinicians to consumers to policymakers that believed this must be done and it was time, to the second generation where we put a tremendous amount of capital investment from the public side into this. We're now shifting gears into this next stage, and I think it's a time that is very much asking what has worked, what has not, and what is the architecture of our policy going forward. We kind of have stumbled into our architecture, I think it's some's work, some's not, but we've got a big challenge coming up, and I think it's probably going to have to be rethought to some degree from the ground up as we move forward. So it's been a great time, and glad that Farzad didn't mess up any of the great things that we got underway. So.
That's right. A lot of continuity there. Well, Farzad, and we are going to talk about rebuilding and next phase. I think that's an interesting way to characterize where we are. It really is some fundamental looks about where we go from here. I do want to talk about that for the next part of our time, but right now, Farzad, your perspective on where things stood when you came in and where they went, and anything that's particularly surprising about where we are right now compared to your perspective when you first took on the ONC job?
There was a lot of continuity, I think, not only in the vision, but David created an office and a culture of innovation and entrepreneurship. And it's interesting, he was an entrepreneur who went into government. I was a govie who now is an entrepreneur. And that idea of, I think there may be some people who expect, if we're having a conversation about the role of government, and we have a Bush appointee and a Obama appointee, that we would have very different views on that. I don't think we actually do. A lot of what we did was really trying to help the market operate effectively. I'm sure there would have been some differences in terms of how we approached it. But fundamentally, we understood, unlike, say, the UK, where there would be a top-down procurement and, we would choose, the government would choose for, everyone what systems they were going to use. And, to this day, I get people saying, like, the government should have just funded open source software and rolled it out to every hospital in America, and then we wouldn't have had these problems. We didn't take that approach. Around usability, right? We actually stepped up to the brink of saying, we know this is a huge problem. Can we, in good conscience, define standards and say, you must be this, this is the usability standard for all health IT in America, right? And we were like, really? You're going to want us? Like, to have that humility to say, you want the government to say, like, this is usable, thumbs up, thumbs down, like the iPhone would never have been approved, right? The font's too small, or whatever. So I think there was the belief that a well-functioning marketplace was our best chance for getting innovation, despite this mandate, right? And I think the challenge that we still have to this day is, how can government exert its levers, and there are many, to help the market reach that stage? How can we shape the field so that each individual actor on the field, playing according to maximizing their interests, yields the best result for society? And I think we still have some work to do. I think ONC still has some work to do in that respect. I think, switching costs being so high, the inability, one doctor, one vote, one time, like, you get to choose your system, yes, right? And when people would come to me and say, like, I don't like my system, I'm like, well, why'd you choose it? Right? I'm glad I didn't choose it for you, right? And that's fine at one level, but it's not fine for government to abdicate responsibility, to say, like, okay, once you've made that choice, you cannot switch, right? If switching costs are so high, that doesn't make a market that works. So what is the role of government in helping create that fluidity in the market, as one example?
Well, let's talk some more about that. So it sounds like the vision for what we needed to get to was similar, sort of a well-functioning market that incorporated interoperability and that fulfilled the potential of health IT. Still on the way to get there. David, I know you've emphasized some in some of the work that you're supporting now through Health Evolution Partners, kind of a bottom-up approach to making that happen. Could you talk a little bit more about what you're doing now and what the implications might be for getting to this well-functioning, not just interoperable system, but one where people maybe aren't locked so much into choices and can really use health IT more effectively?
Sure. I think that, Mark, the best way to describe kind of how we view this, and I think it perhaps is a commentary on policy, is that regardless of how we got here, as you look forward, what you recognize is if we want to have population health management and ubiquitous data that follows patients and having them engaged in their care and using their information, that the unit of regulation is wrong. It's mismatched to that. We're regulating doctors and hospitals, and it's not just in interoperability, it's in meaningful use, and it's also in HIPAA. And this kind of architecture of how we have come about regulating health IT by regulating the providers of care, I think is a very faulty model. It's one that won't take us much further. We could get all the providers lined up to have the capacity to do certain things, to protect information, to make it secure, to make it private, to make it follow the patient, to begin using it for populations. But because they're all separate entities, it may never create the reality of that information being used. And it's kind of where we are today as we debate meaningful use. And so, our fundamental observation is that, the patient should own their data, and the data should be organized and regulated around that person. And, I'll just go back to privacy. We have, enormous challenges in privacy today because certain entities are not covered and they're not business associates. And they can, I don't want to say do anything they want, because we know they can't through general privacy and through state laws. But we have these enormous patches and all these handoffs where there's tremendous risks. And I think it's the same flip side for interoperability and the ability to use the information. And so, when you start with a fundamental observation, say, how do we build things around that patient or the population of those patients, the inputs that we have to drive from a policy perspective are very different. And the mismatch is people like me that are funding innovation. Last year, Health IT had a record investment from venture capital, $4.1 billion. And the numbers are growing tremendously. Everyone thinks about the patient, how to organize it around them, those that touch them, the doctor, the plan, the provider, the hospital. But in Washington, we're still very much regulating the enterprises. And so there's a tremendous mismatch between the two, where innovation dollars are going, where I think the world's going, and kind of where we are.
Let's try to pick up on that disconnect. And just, as far as I do want you to, I want to push you a bit on how to make that connection through policy more to the person level. And it's kind of interesting that at the same time you're having this discussion in health IT policy about initiatives that are focused more on organizations and institutions. We're having this larger debate and movement in healthcare payment systems and healthcare regulation away from siloed fee-for-service types of payments towards initiatives and payment systems that are much more focused on the individual, like the ACOs that you're working pretty closely with now. So if I could just push you to try to make more of the connection here.
So the other thing that's happening on the health reform side, and this today, and it's great, appropriate for it to be at Brookings, is really not about health IT as technology, but health IT and its role and how it relates to health reform. One of the major things that's happening in health reform is the greater responsibility given to individuals for choosing their health plan. Not have my company choose it for me, right? But I go online, I shop for my health plan, right? And the capability to do that and to live with those choices. The proliferation of narrower networks with, restrictions, but you're making that trade-off between premium and copays and network. the huge increase in price comparisons and shopping for not just a health plan, but for an individual procedure, we are pushing more and more responsibility on individuals. And you can't have, shared risk without shared data. And individuals should be able to get their own information so that other people can help them make the best choices for them, right? So having a coach, a quarterback, an advisor, whatever, right, who can help you with that. And the connection comes, I think, through making clear that there are HIPAA requirements that covered entities, including insurance companies, including pharmacies, including hospitals, including doctors, have to give the patients their data. And that liberation of the data to the individual, I think, is a big component of what a lot of the innovators that I hear are just waiting for them. They're like, yeah, it's there in theory, but in practice, I can't create a service for patients that presumes that they have access to the full clinical and administrative claims information on themselves to help them make better choices for themselves. So that is, what's in meaningful use stage 2 that's so hard, right? 2 things. Give the patient the data and share the data with each other, right? So the ability for patients to view, download, and transmit their data to another place in meaningful use is, as we heard, right? Like, it's a huge challenge for healthcare organizations that are centered around the healthcare providers, right? Healthcare is centered around the healthcare providers. It's not centered around the patient, right? What's best for me, right? So that, I think, is a fundamental switch that government can do to liberate innovation and to really push reform forward in this respect.
Right now, you've talked about HIPAA requirements on giving patients data, and I think it sounds like the view from both of you is that if it is easier for patients to get the data, there are plenty of companies and plenty of motivation in the market to help them use it more effectively. I just want to make sure that you all agree on that. I mean, David, you're working with some companies that are would be on the receiving end of better data from patients to help them make more informed decisions. So I want to stick with that one for a second, and then I want to go to the other big issue around interoperability for providers to help them deliver more patient but first, the consumers.
Yeah, theoretically, Mark, I think the assertion is correct that patients with information can deliver better care to themselves and deliver a better result for us as a nation. However, if I had to say what share of the healthcare consuming public all those billions of venture capital are aimed at, that highly mobilized, thoughtful, engaged, information-driven decision maker, it's probably 4 or 5% of the healthcare consumer. It's still small. I think it's growing, but I think it's quite small, trending in the right direction. And so, we have these stratifications. So there will be patients that will organize, manage, collect their data. They're probably doing it now. But I think the question, and this gets back to the policy architecture, of what do we do with the big middle? There's a group of patients that may never do this, fine. But in the middle, there are a lot of people that need help. And I think one of the things that HIPAA has never crossed the Rubicon on, even in the discussions are starting, is to say, well, I'm the patient, I own my data, but I should be able to designate a third party who is collecting and managing, potentially helping me think through what's in that information. And this concept of an intermediary or an infomediary, whatever you want to call it, is not possible today. I can ask someone to send it to that entity, but no one's required to do it. They only have to give it to me. And there's no marketplace for those entities, whether I'm a health plan or a hospital or Google or whoever it might be that decide I want to be in that business. There's no framework where they can build the market around. So I think we've got a system today that's going to support 4 or 5% of the patients, and it's not going to help the 75% until we think about how do we manage data better for them.
All right. I agree that infomediary and enabling being able to delegate someone else. I actually don't know whether that is or is not feasible with HIPAA today. I think it's
not prohibited. It's just not allowed.
Well, let's talk a bit more about it. A lot of that middle are people who depend on their health insurance, their health plans, their healthcare providers who are paid through their health plans to help them make these decisions and get the care that they need. And this is where I want to go back to the alignment or lack of alignment between health IT policies and payment reform policies. So you all have highlighted how the health IT policies need to get more focused on supporting people, individuals getting care for their own needs, which are very diverse and very diverse practice settings. We have a lot of payment reforms underway now that are intended to support that. You're working almost all the time, I bet 24/7 or close to it, it probably seems like, with physician groups who are trying to become accountable care organizations where they are paid in part based on the overall cost and quality of the care that their patients receive. But those efforts have been, while they've made some progress as well, it kind of reminds me of what we've been talking about on health IT, there certainly are a lot of challenges remaining. And a lot of these organizations that I think would like to be the kind of infomediary that David was describing, you know, the primary care providers or the medical home for a patient, or if it's somebody with cancer, the oncologist who would like to have a better visibility into the overall care the patient is receiving, better support for, you know, helping that patient get personalized decisions. They just can't get all the data that they need, and they don't have the, while progress is being made, the analytic tools for them are not really there either. And it does seem like there's still a disconnect between the goals of the payment policies and where we are in implementing them, the goals of health IT and where we are in implementing those. I wonder if you all could talk a little bit more to the challenges from the provider side. So we've talked about consumer, but more from the provider side for what federal policy could do to make it easier for them to be the infomediary for a patient, for them to really take on more than just a little bit of shared savings accountability for better results and lower costs for patients. You want to start?
Sure. So my practices can't get their own data, much less other people's data.
That doesn't sound very encouraging from the standpoint of interoperable data.
Time to end the meeting.
So they've paid for a license to an EHR. And they didn't have the ability to negotiate that contract very much, let's be honest. Right? And in that contract, you know, they have to pay and pay and pay and pay if they want to get access to their own data. And you know, that was a problem we tried to address through certification. We said, hey, you got to be able to do a batch download of consolidated CDAs for all using the meaningful use common data set for all the patients in the record. And they all...
When you say batch download of CDAs, just for our
so
non-immersed audience.
Yeah, so every patient, but the technical details matter, right? So for every patient in your practice, in that EHR record, you should be able to download a care summary of the labs, the diagnoses, the procedures, the medications, the visits, all that stuff. 16 segments. That the ACP did the survey of physicians. They said, that's what do you want? That's what they wanted, right? You should be able to download all of that. And if, transparency requirement, if the vendor did not say you need to purchase any additional software, then you don't need to purchase any additional software. By buying that stamp of certification, you should be able to get all that.
Okay, so this is one of those things that sounds good in
theory.
But
in practice, you go and I'm just amazed when I talk to ACOs around the country. They're like, A, we didn't know about this. Right? We had no idea. So the customers aren't taking advantage of the regulatory apparatus, right? That is designed to protect them, so the customer support. And B, when they do go, the vendors say, oh, that's just for certification. You really need to pay us $15,000 to get a real interface, right? So there is, before we talk about, sharing interoperability and sharing information, like the step one, and this is a precedent for everything else that we're talking about here in terms of using government levers, is you have to have enforcement and you have to have empowered customers demanding their rights under the regulatory apparatus that's been set up to protect them. And without those two together, I fear that everything we do around shifting incentives for providers won't translate to shifting incentives for the vendors, because you can, what the payment policies that we change now make sense for the provider to want to share information, but the vendor's still making $10,000 a pop on those interfaces. We have more standardization. You reduce the cost to the vendor of building those interfaces, but you don't reduce the price necessarily.
Now, the first panel also emphasized these themes around interoperability for better quality. You're not going to maybe have every bit of data completely interoperable at the beginning, but you highlighted 16 elements in the CDA that the ACP, the primary care physicians especially, thought, okay, this is what I'd really like to know in an up-to-date and accurate manner about my patients from wherever this information might come from. I'd expect there are sort of similar practical requests that oncologists, orthopedists, others might have. It might not be the same 16 elements, but it's some core information. And if that's not happening, so one response to that, one policy response, as you emphasized, could be enforcement. I guess the other that I'd like to ask about is, are the incentives really there? I mean, you said that what you'd heard from the EHR vendors is, well, we've checked the box on certification. We're not really focused on, I'm putting words in your mouth, I think, but maybe not. We're not really focused on incentives for critical data actually moving to be used for improving patient outcomes and reducing costs. And if that's the case, is there, just again,
for
we're
a
going to
fee,
keep pushing you
for
all.
a fee, of course,
Okay.
will enable that.
But what does that mean for federal policy? So one answer could be, well, let's enforce the standards that we have. Enforcement can work. It can take a lot of effort, though. Are the incentives right? I mean, are the payments that are going for meaningful use going to the right things if it's not achieving this, what you just described as sort of the critical goal for healthcare providers?
Well, Mark, I think in a lot of ways what we're living with are the real-world consequences of decisions that were made around high tech to put adoption of electronic records ahead of interoperability. They were running kind of neck and neck for a long time, and interoperability has not moved forward. And so what we have is a legacy vendor dominant enterprise-based world, as opposed to a world where the data lives in the network, the information is liberated there, and the end-user appliances are quite light, have very little leverage, and are not barriers. So, we have this reality today where, to your question about what role should providers play, I think the overwhelming share of providers are not qualified to be an information manager on behalf of their patients. They don't have the technical depth, they don't have the sophistication, they don't have the budget, they don't have the scale. And should they be accountable for doing that as the entity we look to say you must do it, as opposed to the delivery entity? And we're talking about a new class of vendors, perhaps. But there are a lot of entities that manage very large scales of data in a very sophisticated real-time way with good security and the other pieces inside and outside of healthcare. So, we have this class of providers that I think are on a learning curve and they're getting there, but they're not going to evolve across the nation into a class of entities that are going to meet those goals. And I think the sooner policy recognizes that providers are consumers of information, they need it. They don't have to be the people that actually do it. And maybe an entity like Farzad's could do it, or a health plan could do it, or an information company could do it. Suddenly I think we start being realistic about where those competencies and that capability and that capital investment are. The other side of it is that I don't think we're going to migrate our vendor class into that world. Some may choose to do that, but I think a lot of them are kind of trapped in this meaningful use paradigm where it's hard to innovate your way out of it. It's hard to take that and disrupt yourself and become a new kind of company or a new kind of solution. So I think we've kind of come into an end pocket where we're missing a class of entities who are commercially strong, who are viable, who are regulated to deliver information. And we're not going to whip providers into it. We're not going to coax and incent vendors into it.
That's a pretty fundamental point, but it sounds like we need to change the meaningful use paradigm if we're not getting, and by that I mean capital MU, meaningful use, incentives, requirements. It sounds like you're talking about a pretty significant change in that paradigm.
I guess I could see this building instead of a different, totally scrapping. The farm analogy I really like, Mike. When we started in 2009, for meaningful use stage 1, let's take medications, right? Like everyone understands that, right? Like you're going to share medication list, like a huge safety issue, right? We had to say, for stage 1 of meaningful use, you can use any of the following terminologies for medications. Right? Remember that? Because we couldn't get agreement. Every different system, one group used NDC, Metaspan, First Data Bank, and we said, hey, okay, let's standardize on, you use any of those that there is a mapping to Rx norm, and by stage 2, everyone has to move to Rx norm. So if we had, and by the way, you have to put the orders of the medications into the system electronically, not hand scrawled on paper. So, if we'd had interoperability of that paper analog, thing that wasn't coded and wasn't structured and didn't have a common terminology, what good would that exchange have done, right? So maybe Google's, I don't know.
That's what Google search
maybe,
is all
but
about.
I guess my point is that there is value that we have created. Maybe there was another approach to it, but the fact that we now have healthcare processes generating at high cost, like it has been painful, there has been a lot put into this. I think there is value there too. The fact that healthcare processes today are generating medications and diagnoses and procedures and labs and all that in structured, standardized terminology format that now can be shared and have more value.
And are being shared, are being accepted, and are having impact on care.
And the point was made about quality measurement, right? If we're talking about health reform, there is, and like we're going to pay for outcomes, not more stuff to be done, right? It's easy to measure more stuff being done, hard to measure outcomes. It is hard to imagine being able to do quality measurement unless you have some assurance that you're collecting, the basic data that you need to calculate quality consistently. So, are we collecting blood pressure in the same way across different systems? If that is overly specified processes, I guess guilty as charged, but I don't think so, because we didn't say you have to collect it at this stage, you have to collect it using this kind of cuff. We just said somewhere in the record you have to have systolic blood pressure and diastolic blood pressure, and this is the terminology you have to use. You knock yourself out in terms of how you do it. So I actually think that we have created a necessary information infrastructure to be able to do consistent quality measurement and, yes, sharing of information that is meaningful to machines, right? It's not necessarily meaningful to a doc getting a 50-page printout of a whole bunch of structured data elements, right? I recognize that, but the machine-to-machine interoperability and quality measure calculation and feeding that new world is a big advantage.
Stage 3 of meaningful use is supposed to be about that, right? It's supposed to be about information being used to show measurable impacts on outcomes of care, quality of care, costs of care. Right? No? He's kind of smiling. And the next question is going to be, that's looks like it's going to be 2017 at the earliest. So I'm just wondering when we're going to get out of this cul-de-sac that David was describing, where we've gone with, where you all seem to be saying that current meaningful use requirements have taken us to get to
I thought he said on-ramp. He may have said cul-de-sac, but I heard on-ramp.
Where did that ramp go? But or is it time to change the federal policies for meaningful use, to make them more about these results and less about the processes and technical capabilities to get there?
So look,
time now, not 2017.
We could have a great time debating how we got here and whether it's the most efficient way, but the truth is we are where we are. So looking forward only, to me, one thing has changed that we have not really gotten our arms around, and it's on the periphery, but it comes to the core of this tie-in between technology and money. And that is that we do have ubiquitous information. We have a consumer that is aware of it. Many people can't manage it. But people recognize this, and we all know the value that assembled data has. All right, how do we handle in our health society things that are deemed necessary for medical care that used to be not covered? Well, we cover them as a health benefit. And we've got some early experiments with this, with some plans starting to have health information as a benefit and then going off and contracting with providers to collect that data, just like the plans collect all the other information required that services be delivered.
Fee for data.
Well, I think the great thing about this is If it's fee-for-service, fine, you can do it that way, but if it's some kind of a bundled care or episode payment, it just gets bolded in. The point is, the insurer is being paid through a premium to collect that information, just like they're being paid the actuarial value of the 0.72 MRIs that people get throughout their lives and the 6.2 medications they're going to take that year.
The other things in the bundle.
It's part of the MLR, and it's administered through the same way we collect that value I like an MRI. That's just a bunch of data, too, that happens to be organized in a useful way that we can do something with it. And it can move across payment forms. And I think that is the fundamental reality. If once we recognize that health information is simply a very valuable asset, and we need to administer it the same way we administer every kind of diagnostic or therapeutic information driver that we surround ourselves with, it's an easy problem.
The same shift to the patient level rather than the
it's all patient level because it's part of your plan.
So
I would say it won't matter until CMS makes a coverage decision and says this. Once that's done, meaningful use is absolutely irrelevant. It's a Band-Aid that helped us get someplace that we no longer need.
I think the big push is towards alternative payment models where you're rewarding outcomes. And the challenge has always been, okay, you can measure cost. That's a pretty clear outcome. But the last time we tried to focus only on cost, patients and the public revolted because they said, how about quality, right? And what we have to do differently this time is we got to be able to demonstrate that we're, in my business, right? We have it at series of ACOs. And my first letter to all of our docs was, okay, guys, number one, we're never going to save money by stinting on care, right? There are plenty of better ways for us to do this. We will never do that. We will always do what's right for the patient. I worry that there are a lot of other ACOs out there who are going to take shortcuts, right? And unless we have policies that are in place to protect patients and to keep faith in society that these alternative payment models aren't just managed care wrapped up in new wrapping paper, right? That unless we can have convincing, high quality, variety of quality measures that are generated as an exhaustive delivering care.
Generated
right?
from care,
From
not
care.
not added work for the physicians.
Then this whole thing doesn't go forward. And I think it is an on-ramp because now that you are collecting smoking status and blood pressure and the medications and right, those are the raw materials for being able to consistently generate that. But the system right now, the point is reporting. The point isn't outcomes. And so you get people who didn't, vendors, systems, implementers, providers who didn't prioritize the purpose, the meaning, the outcomes. They prioritize just check the box and do the thing. Can you collect smoking status? Yeah, you can. It's buried 15 layers deep. Did it have to be? Did the regulator force you to make it 15, clicks away? No, the regulator didn't make you do it, but you didn't care because it was a compliance requirement. It wasn't an outcome that you were driving towards. What we need to do for payment policy in stage 3 is to make those outcomes really matter.
This has been a great discussion. I want to open up to
Can I comment on that before you do that?
Okay.
I agree with you that in Nirvana, payment for quality or for health status will solve this problem. But
2018.
no, that's not going to happen ubiquitously across the way we pay for care.
So you're going to say something about how to get from here to there?
In the world between fee-for-service and that, where we have things like episode payments or bundled payments that aggregate doctor, hospital, lab,
Or
pharmacy.
shared savings or things like
Sure.
that?
These intermediate things which we could live with for years, those should have embedded in the actuarial component, what is the information that has to be assembled for that episode to be delivered, and we have to contractually manage that information in a way that we can get it to the people that need it.
So it's about the critical information, not about the certification.
Embedding it in the payment mechanisms and getting rid of the intermediate structures.
Okay. I know you guys could go on for a while. Let's see. Questions back? There's one right here.
Hi, I'm Sharon Fay. I'm the administrator of a ACO in Northern Virginia. And I have a question a little bit different, but back on patient-centered medical care. Trying to be at the provider side, and we're all primary care in our ACO, there is a huge responsibility for the provider to try to change the behavior of the patient. And as long as the incentives are still directed at the provider and not combined and aligning us together, how do we move forward and not just trying to check off all the boxes, whether it's meaningful use or certification or anything?
Mark?
Well, no, but I'm just the moderator here today, but I would just following up on the question. I mean, we have been talking about meaningful use programs that are really focused on the providers. And David, you made the point earlier that there is a growing component of the population that is really engaging in data. And it seems like it'd be nice if we could take that from 3 or 4% up to a much larger percentage more quickly.
Let me give an example. Oh, go ahead.
Well, I would just say look no further than consumer-directed health plans.
Yeah.
Where, yes, there's skimming because people do choose to opt into them. Sometimes they're forced by the plan design and the employer, but where people opt in, there are tremendous behavior changes that they enact. They have the information, they have the incentives, and it's a skimmed group of people, but I think that's showing that it can work. So to me, how do you create that same incentive structure in the ACO environment? And I know some are looking at that and some are not, but this is doable. We have evidence across 15 million people that it's doable. We just have to figure out how to put it in.
I was pointing to Mark because Mark, in his comment to CMS on the ACO, said that Medicare should allow for beneficiary design, so that if you do go to your primary care provider, who is you're attributed to, then you can waive copays. You can have incentives built in, and if you go somewhere else, then you have to pay more. So that I think is fundamental. It would require that you actually know who someone's primary care provider is, which right now outside of managed care you don't know. People never have to say, this is my primary care provider. They never have to announce. And that, I think, is also a Brookings recommendation, that people be able to affirmatively say, that's my primary care provider. Fairfax Family.
I think I have time for one more right here.
Adrian Gropper, Patient Privacy Rights. The JSONs introduced the concept of a public API, and as many of us are working to implement that technically, what is the role of regulation or policy in establishing the patient's right of access, and as you very clearly said, the patient's right to delegate to an intermediary, as we try to struggle with the role of stage 3 or HIPAA interpretations, which are very different in terms of enabling the JSON, the public API vision?
Okay, and in answering this question, can you all build in a brief tutorial on API and public API?
So the idea is that when you have machine-to-machine communication, there should be some predictable responses, right? So if I do this, you'll do this every single time. And it's meant for more synchronous, two-way communication, so that I can potentially plug it in, right? I plug in, you have this EHR, I plug in an application that pulls data and pushes data, asks for the information, and acts on it. And the vision of that is that you can have more loosely coupled systems as opposed to monolithic, one architecture, one vendor that builds all parts of it. And I think it's a wonderful enabler of the kinds of innovation that we want to see. There's also some magical thinking, right? Because having an API doesn't mean that I have to turn it on to you, right? Twitter had a great API. They spawned all sorts of companies that built on Twitter, and then one day they woke up and they said, oh, you know what, we're shutting off the API. If anything, APIs give more control to the data holder, because they can say, I'll give it to you, but not to you. I'll give it to you this way. I'll change it this way, right? So without having additional protections built around, additional policy built around who can access it, when can they access it, how much it's going to cost, it's a little bit of techno-engineero idealism to say, like, through a standard, we're going to solve business problems.
There's so many cool terms that come up in this kind of
That's the great thing. No one knows what you're talking about, right?
Well, yeah. but in terms of this question, I mean, this useful data controlled by consumers seems really critical, David, to the kind of initiatives that you've been talking about.
Well, I think it's a simple triad. If patients were able to get their data in real time, in a detailed electronic format, and allow a third party that they designate to collect it on their behalf, we would have the problem solved. We have the world today where I could take 120 days and I could send you a PDF and I could refuse to give it to anybody but you. And not only does that make it inconvenient and frustrating for patients, and it creates all kinds of other risks, we can't establish a marketplace where people say, wow, if I invest in the infrastructure to become a great service entity to my patients, I could do this. And so those are the three changes. They've been well known. There have been testimony on the Hill 100 times about this. And during ACA, we took some steps towards this. We repaired some of the breaches But we're not done. This is not a patient-centered HIPAA environment. And until it is, the world that you live in, I think Farzad's right, will be technically capable, but perhaps not really used.
All right, so yes.
Can I just add one thing? We've talked about government role in health IT and health reform. There's one thing that I think David and I agree on, which is...
There are a lot of things it seems like.
Yeah, absolutely. Which is around the safety.
You like your bow tie.
Thank you. Which is around the safety issues. There is a, it's very easy for the public to feel like one of the roles of government is to protect patients, right?
Yep.
And when there is, and I don't think it's a question of if, it's a question of when, right? When there is a very public patient harm due to health IT, right, case, which is, charismatic in some way or another, there will be all of a sudden this industry that has kind of said like, oh, we don't want to be regulated, and oh, FDA shouldn't regulate us, and oh, well, maybe we don't really need the safety center, right? All of a sudden, the regulatory apparatus is going to come down on them like a ton of bricks.
Yep. And I think the burning platform for that is going to be security breaches. We saw Anthem, we all know about that. I think there are two kinds of healthcare information organizations. There are ones that know that they've been hacked and ones that don't know they've been hacked. And there's not much in between. And, as those mount, I think it's going to create a burning platform that I think will drive potential congressional action across this whole bundle of health IT actions. So I actually am bullish that we're going to see near-term action, because I think the inevitability of those hacks and breaches are going to be quite loud and quite large.
And that you think the positive result of that, scary as it sounds, is that there will be health IT policies that focus more on the bundle of results for the patient.
Yes, I think you have to move those things together. Interoperability, privacy
and
security move together,
safety,
because they're aspects of the same coin.
And get away from particular provider certification requirements, particular silos. It's time to move to the real patient focus.
I think once we examine it, we'll see how naked that model is in today's world.
All right. We're going to pick up on some of these themes with Karen DeSalvo after the break, and then with our third panel on where we go from here. But right now, I want to thank David and Farzad for an excellent discussion.